Okay, so we were talking about the foot and ankle, and we were just getting to bone injuries. So let's go and talk about some of the bone injuries that we can see in the foot and ankle here. Uh, let's see, Ashley, what do you think of this case?
So the skin markers along the no, the plantar aspect of the foot, and I'm looking at the bones. Is there some superior? Oh, there's degenerative changes, or is that a fracture? That's
Well,
post-traumatic.
yeah, this is actually what I was looking at.
Yeah.
You can, after trauma, you can, if you injured the ligaments, you can get subluxations, and sometimes they can become chronic. And this is just a chronic subluxation there that was post-traumatic from the past. Jennifer, what do you think of this case?
So here we can see an overlying soft tissue marker along the dorsal foot, and there is some edema along the talonavicular joint. Could be degenerative changes or perhaps a sprain of the ligament, depending on the history. There's some fluid signal there as well, and some thickening of that ligament.
Yeah, so this is a very common source of injury. You've seen many of these already in the fellowship. It's that dorsal talonavicular ligament. It often gets thickened. It's also an area where you can get large osteophyte formations here, as we've seen in the past. But that's another common area where you can get kind of overuse injury to that. And the mechanism is kind of debated. Some of it may occur in sleep where you hyperflex the foot and produce chronic strain on that dorsal talonavicular ligament and capsule, causing it an injury, and then it can become thickened over time. But it's a common location for degenerative disease.
When you say dorsal, I used to think of it as anterior.
Okay. Yeah, I usually use plantar or superior. I guess you could say anterior, but most of the people I've talked about use dorsal for the superior part of the foot here. But you're right, that can be very confusing.
I think that's, like I said before, it depends on what book you read, and it's very confusing.
That's really a good point to make, John. Okay, Ashu.
Looking at this prominent ostrigonum here, and then there is a lot of spurring at the talonavicular joint as well, and there's fluid there. Yeah, talar beaking.
Yeah, this is that spur that you can get, just like you said, at the capsular origin there on the talus, and it's often called talar beaking when you get this, just a chronic traction injury and osteophyte formation in that location. Jennifer. Plate film on someone who had trauma and ankle pain.
Here we have an AP film of the ankle. It seems there may be some slight widening of the medial ankle mortise. And then here on the MRI.
Now what this is a very old MR scan. It's a T1 weighted image. Back in the days when the we had to image both feet together because there wasn't room to be able to put one out of it, and we had to use the head coil. What we can see is signal loss within the bone here, and a little linear loss of signal here in the medial malleolus. And this is just to show that the plain film was really quite negative, but we can see an extensive amount of bone injury on even the T1 weighted MR scan. So this was about back 1987, 88, when we were just beginning to look at bones. So I don't think we need to go through this. Okay, so Ashu, what do you think of this case?
24-year-old male with pain while running. CT to evaluate for fracture line. I think that we're just getting the cut here, but I don't see a definitive fracture.
Not there, but you're right. Here are the axial images through that area. So
yeah, I mean, I think you're looking at the navicular bone here, but I don't see a fracture.
Okay. Here's the MR scan. Here's in the coronal plane. Here's the axial plane.
Yeah, this is much clearer here. We can see, you know, some. I would call this stress injury or overuse injury, some trabecular injury for this runner.
Yeah, so it's overuse stress injury. This is very common, and you know, it's in children. It's often called Kohler's disease if you start seeing X-ray changes and reactive changes there. But these in the literature, these kind of changes, if you see bony changes, are typically called osteonecrosis. But I think it's pretty overwhelming evidence now that the vast majority of these are due to repetitive trauma. They start as trabecular bone injuries. If they're not allowed to heal properly, then you can go into bone collapse and destruction. Jennifer.
So we have foot pain after trauma. I don't see a discrete fracture here. Okay, but here we have the soft tissue marker along one of the metatarsals. I can't tell if this is a fourth or fifth metatarsal. Okay, so this would be a stress fracture.
Yeah, and here we can see the increased signal intensity, the edema around the bone, and this was a stress fracture. And as you know, the majority of these are negative on X-rays. Ashley, what do you think of this X-ray?
John, after 10 days, you start to see them.
Right. Yeah. Yeah. So in the old days, we'd bring the patient back in 10 days to 2 weeks to re-X-ray them. Then we started getting CTs, but now we just get an MR scan.
We treated them before we re-X-rayed them because you can feel the tenderness. Usually it's the second metatarsal, and you feel tenderness to palpation, not just pain. And the pain is quite significant when they walk. This is March fracture. That's the common name for it. I don't know if it still is, but it used to be.
Yeah.
March fracture, and that recruits that come into the Army.
Yep. Okay, Ashu?
Seen a lot of
them. So I'm guessing we're looking for another fracture. Maybe some irregularity of the distal fourth metatarsal. I don't know.
You're right, I think.
Yeah. I thought it was the distal fourth metatarsal. It might be a little irregular, but I could be wrong there. And then
right here.
Yeah.
So what is this?
Is that a normal apophysis at this age?
That's right. Exactly. Good. Yeah. And then here, maybe a little wide in there, but you're right. Exactly what you're seeing here is a buckling of the cortex in the distal fourth metaphysis. Here's what the MR scan shows.
Yeah, much more clear on the MR. You can see the fracture.
Well, that's a common stress injury there in the second and the first metatarsals and the heel. So that's a tripod. The foot consists of. That's the points where the most of the pressure is in normal feet. But a lot of feet are not normal.
Right. Jennifer, what do you think of this case?
Okay, so here surrounding that second metatarsal, there's a lot of muscle edema. This can also be a sign of a stress reaction or acute stress injury.
Yeah, and you see edema within the bone there. And this is another X-ray called fracture of the. Yeah. In this case, this was the second metatarsal, as John was saying. Okay, Ashu.
So 31-year-old female with pain and swelling for 3 days, no trauma. This is on September 2nd. We see some, especially on the T1s, low T1 signal of the fourth metatarsal, some increased soft tissue edema. I don't see a fracture. Yeah, you can see that soft tissue edema extending to the muscles.
Okay. So
And now,
this is 9/2. This is 12 days later.
yeah, so I'm guessing they didn't stay off of it, and it developed into a fracture mid fourth metatarsal.
You can actually get bone injuries that may be subtle, and the issue is in a lot of these small bones, you don't have a lot of trabecula, and you can injure the cortex if they're minor injuries without getting a lot of edema or hemorrhage. But we can see a lot of hemorrhage on the outside, so you have to be a little suspicious on these. If you see a lot of edema like this, to be concerned that this could be a subtle stress fracture, even if you don't see the edema in the bone. This patient was on and actually
you have to treat them as if they were going to be a fracture, because what you have now needs an open reduction.
Okay.
Chances are will not heal. Metatarsals in this area and proximal to it are very difficult to heal if you're not careful with what you're doing, especially the fifth one. But the fourth is also at risk.
Good. Okay. Jennifer?
Okay, so this is a 19-year-old female with trauma and sixth toe pain. It looks like she has a congenital variant where she has an extra sixth digit proximal and distal phalanx.
Yeah.
And gosh, I don't see anything acute on the radiographs. This
Right.
is some kind of syndrome, probably.
Yeah, it was just a congenital anomaly. I don't think it was related to any other changes. Okay. Ashu?
Do we know if the other foot had it?
I don't know.
A lot of folks in infancy would have removed that
Yeah,
entity to help with the shoes,
right.
unless you really want it to be a swimmer.
Okay. Ashu?
So this is a 2-month limping for 1 month. So obviously very young patient. Oh, man, I don't see.
Male.
2-year-old male. Okay, yeah.
For 2 years, 1 month infants don't walk.
Yeah, exactly.
I don't teach you that in radiology or not.
Okay, so this is a toddler fracture. You can see a non-displaced spiral fracture of the distal tibia, significant edema surrounding it. Might even be some hemorrhage.
And here's a CT scan.
And you can see some periosteal thickening there, and an incomplete fracture.
And here was a follow-up a month later.
Yeah, I did not see it on the first radiograph. Here it's a little bit more obvious. You see that lucency and yeah, I don't see it here very well.
So you're right. That's a toddler's fracture. Okay, Jennifer.
So we have a 34-year-old with left foot pain, rope swinging, and hitting a rock with the foot forward. Symptoms for 1 week. Okay, so here we have some edema in that second metatarsal base and third metatarsal base. It's near the attachment of the Lisfranc ligament, so I'd be concerned about an injury of the Lisfranc ligament.
We don't see another structure there.
Yes, I don't see a normal ligament. And then here we can see some fluid and edema in the normalis frank ligament. It looks like that plantar aspect of the ligament is disrupted. So this is concerning for a Lis Frank injury.
Yeah, and there's a little bit of displacement here. So,
That's some sclerosis too, isn't there, John? Is that, how old is this?
yeah, this is pretty recent injury. So,
Well, it certainly looks like that on the second and third metatarsals. There's some sclerosis of the second one medially, but I'm just guessing on it.
yeah, so this was an injury of the bones with an injury to the Lis Frank ligament. And when you see the injury to the bones like that, and even with a very minimal displacement, most of these are treated surgically.
If in doubt, treat it. If you don't have an MRI, the best thing to do is X-ray the other foot.
Okay. Yep. And here we can see there's instability there with dorsal displacement of the second metatarsal base. More severe injury. Past this, but I don't think we need to keep going through all of this. Okay, Ashu.
So 26-year-old female had an ankle sprain. We can see fractures of the posterior malleolus here and also the lateral malleolus. And
Medial here.
and medial here, right?
Okay, is the
Prime
posterior,
malleolar fracture.
let me ask you a question before we go on. Is the posterior malleolus a problem here?
I'm guessing no.
And that's correct. Is the medial malleolus a problem here?
Yes.
Big time.
Yeah.
Okay.
What's the mechanism of injury here?
Supination, external rotation.
Yeah, it's a typical eversion type injury, right? It's traction on the medial malleolus, pulling it off here, and then you're going to end up having kind of an oblique fracture on the lateral malleolus, which we can see on the axial images here, and then the little right. So that's right.
It's probably a rotational component too, John.
Yeah, I think there's a rotational component as well, right?
These are, you have to open, reduce, and fixate.
Yeah, so here you can see.
You don't have to fix the posterior malleolus, though.
Okay, good. Okay, Jennifer.
Okay, so 13-year-old male pedestrian injury, eversion, external rotation. We can see here that there is a fracture of the medial malleolus, and yes, it will be a Salter-Harris 3 since it extends to the growth plate.
And then there are a lot of classifications, but I think generally, like in a lot of the areas we've been talking about, I think it suffices really to just describe the fractures, try to think in your mind the forces involved to call those, and then depending upon who you're working with, what the orthopedic surgeons, what kind of classification system they use, you can classify it as they like it. But most of the surgeons, again, that I work with like to describe it, and in the radiology report. Okay, Ashu.
16-year-old ankle pain after football injury. I think there's some partial tearing at the deep deltoid ligament. I see some increased signal there. And there's a lot of soft tissue edema.
Okay. So that's what a lot of soft tissue edema. So, so what would the mechanism of an injury like this be?
Well, I think we'd have to look at the ATFL and PTFL because you could get contusion, but this is, with an inversion injury.
Let's go to the axial images now.
There's a lot of, I don't, it looks like this is a little too high, but maybe this is a tear of the ATFL here.
No, we're too high for the ATFL. So basically what happened here is you've got an inversion injury. You've got distraction on the deep deltoid here, producing a tear of the deep deltoid at its attachment to the talus. So then here's the high axial images, and we actually see a tear of the anterior tibiofibular ligament up here. I don't see fluid really in the syndesmotic regions. So this patient really has a high ankle sprain. Now, if we get down to the anterior talofibular ligament, what do you think?
That looks intact, actually.
Right. Okay. And
Do you think that the fibula is a little separated from the tibia and talus, John?
the fibula?
No, right here, there's a separation of tibia and fibula a little bit because of the high ankle sprain.
Yeah, there could be. So
You need to compress this back in place. I think there's some displacement there.
a little bit. I think you're right, John. But so that's the mechanism. So in this mechanism of injury with a football injury, where else can you have problems?
You mean more proximally?
Yeah.
You can have a fracture more proximally. Yeah, fibular fracture. So that's what I would be worried about.
So this is the distal end of a Massonneau fracture. So you just have to always keep in the back of your mind that these kind of injuries can be associated with a proximal fracture. But we don't examine the patients, and we don't know about their symptoms more proximally. But if you talk to the referring physician, it doesn't hurt sometimes to mention that because you don't want to miss it. John, what do you think?
I don't know about this Frenchman, but we didn't use that terminology where I come from.
Oh, okay. I think I may have some more examples here. So, Jennifer, what do you think of this case?
Okay, so we have a 19-year-old fall from 1.7 meters height and pain and difficulty weight bearing. So we can see here that there is significant widening of that medial ankle mortise. On the lateral view, there's also some slight posterior subluxation. And then we can see that there's a comminuted fracture of the mid-fibula.
Yeah.
I guess this could, I'm not sure if this is a Massonneau fracture.
And then here's the MRI showing the edema.
Surrounding intramuscular edema and widening of the syndesmotic interval.
Yeah. So this is another Massonneau fracture. And this kind of shows through the injury. You have an eversion type injury. You get widening medially with a tear of the deltoid ligament. Then if you get a tear of the tibiofibular ligaments, you have to be concerned because that could be the tip of the iceberg of a tear all along here involving the interosseous membrane coming up to a proximal fracture. and this is the Mesonew fracture. All of that.
You have to reduce this and put screws through it for 6 weeks. After that, you can remove them. If you don't, they're going to break.
Okay. And this just kind of shows examples of the mechanism involved there. Okay, Ashu.
All right, so we have a distal fibular fracture here, and the arrows are pointing to low signal that's kind of within the fracture site. I think this is trapped periosteum in this patient with a distal fibular fracture, or and this requires surgery.
And it's another anterior tibiofibular ligament tear with a little bit of edema here in the area of the syndesmotic ligaments. And this was entrapment with a deltoid tears. Okay, Jennifer.
So we have a 7-year-old male who had interposition of the periosteum in the distal tibia, Salter-Harris fractures. And so on the initial exam, we can see that cortical irregularity in the distal tibia metaphysis region. And then here we have post-reduction. There's a little bit improved cortical step off, but we can still see the fracture plane. Okay. And then we have some coronal and sagittal MRI images. And so that fracture fragment is really not significantly displaced, but medially there, it looks like there is a linear low signal intensity periosteal fragment kind of displaced in the physis.
There's
And
some widening, isn't there?
Right here.
Yes, there is some widening of the physis there with some, maybe perhaps some fluid.
Yeah.
And there's posterior distal tibia fracture, I think.
Yeah, right here. So this when they went in and removed this. Okay.
What did they do with it? I see an open procedure, but I don't know what they did with it.
I think they just pulled out the periosteum here. It was.
I see that it's strapped in there. Yeah. Okay. I'm not sure that. Well, I'm not sure that's necessary, but whatever.
Yeah, it's as we talked about before. That's kind of debated, and I don't know of any definitive evidence whether it's best to remove it or not. I've seen it treated both ways.
No harm, no foul, I suppose, unless you got an infection.
Ashu?
9-year-old female. We can see some widening along the medial aspect of the distal tibia's physis, and I think there is also some trapped periosteum here.
Yep, I agree. That was just another trap down. Jennifer, what do you think of this case?
Okay, so we can see that it looks like there's oblique fracture of the lateral process of the talus, which is mildly displaced. There's surrounding edema, and there's also probably an osseous contusion in the distal fibula.
So what's this kind of fracture called? Yeah, it's called a snowboarder's fracture.
Okay.
It's this very characteristic fracture that snowboarders get. Yeah. Axial loading with dorsiflexion and eversion.
With all the things that the snowboarders do, they must have a dozen or so different kind of fractures.
Yeah, I bet. Yeah. Ashu, what do you think of this case?
Looks like there's a lot of edema and a fracture of the lateral talar process. And it's not displaced, but yeah.
Right. Okay. Jennifer?
Okay, so there's lots of edema here, kind of within the neck of the talus, and it looks like there is some impaction
Yep.
there. So I guess there's an impaction fracture injury.
And impacted against the calcaneus. Good. Now, Ashu,
What is one of the things I have to worry about, that talus, Jennifer?
So they will need to limit weight bearing. I guess they could develop necrosis of the talus.
Yeah, correct. It's the distal portion of the talus. The neck, that's where the vessels go through, and then you get AVN distally.
good.
I don't know if you get the AVN of the dome. Probably not.
All right, so a 17-year-old female with shin splints and lateral pain with increased running. Evaluate peroneal subluxation or tear. See a PD fat saturation image. What I can see of the peroneal tendons looks okay. I think there's some irregularity. Maybe there's some edema, the distal fibula. I don't know if there's a fibular fracture here as well. Yeah, I see. It could be a failure fat sat. Looks like it's real. The ideal sequences looks like that edema is real.
Yeah, so
Posterior
this
images.
is certainly
Yeah.
abnormal. There is real edema on the.
Yeah.
So what do you think this is?
Look, I think this is a stress fracture
Right.
of the fibula.
Yeah, exactly. Right. Good. Jennifer? I don't know why this one's here.
Okay, so here it looks like we're looking at the great toe MTP joint, and there's some decreased T1 signal and edema within the tibial great toe sesamoid. This could be seen with avascular necrosis or sesamoiditis.
Yeah, I think when you get edema in the sesamoids here, I don't really think it's. I
There's
don't
a
like to use the term sesamoiditis.
isn't it medial sesamoid subluxed laterally?
Yeah, I don't know. Maybe a little bit. I'd like to look at the other images, but yeah. So
Yeah, right there. That's where it belongs, next to that little thing there.
yeah. So in this area, I'd want to look at all the other images. Be concerned about whether you could have an intersesamoidal ligament tear, and then maybe splaying of the sesamoid bones. This happened to all actually be in that medial sesamoid. I don't think that this is AVN, and I don't think you should use the term sesamoiditis either. Now these are fractures. These are injuries of the sesamoid from trauma.
Yeah, that
Just,
medial sesamoid is displaced laterally, isn't it, John? There's got to be a
it
space
may be a little
between
bit, maybe a little bit displaced laterally. I think you have a fracture. I think there's probably some edema within the intersesamoidal ligament here, due to primarily, though, this is a fracture of the medial sesamoid.
You usually have a considerable gap there.
Yeah. Here we can just see traumatic injury and edema within the lateral sesamoid here, or the fibular sesamoid. You can see there. Ashley, what do you think of this one?
There's significant edema of the sesamoid, and I think there's linear low signal extending through it. So I would call this a sesamoid fracture.
And here, axial. So, you can think about bipartite, but this is too irregular. You don't see nice corticated margins. It's not really straight across. Yeah, this is a sesamoid fracture. Okay, Jennifer?
Okay, so here again we're looking at the great toe sesamoids, and there's a lot of edema and fluid along that tibial great toe sesamoid. There may be a fracture. I can't tell if there's an ossific fragment distally or if it's just a tear of that plantar plate distally.
Here are the axes.
Here. Okay, so here it looks like there are two separate ossific fragments, so it looks like there is a fracture of the sesamoid.
Yeah, this patient was a football player. This is one of the forms of turf toe. In this case, it's a sesamoid fracture.
You fix these nowadays with tiny screws.
Oh, okay. So it gets us kind of into the concept of turf toe. And here we can see the medial and lateral sesamoids, the intersesamoidal ligament here. And then we have the medial sesamoid phalangeal ligament, the lateral sesamoid phalangeal ligament, the metatarsal sesamoid ligaments in these areas, and then the flexor hallucis brevis tendons coming in, attaching to the proximal aspect of the sesamoid. So turf toe is really an injury to any of these structures. It was originally back when they first started using artificial turf in football fields. It was much harder than the people were used to playing with grass fields, and that lead to increased traumatic injury from pounding of the first metatarsal phalangeal joint space area and get injuries to these structures. So these are the structures you really have to evaluate, as well as the flexor tendon. Okay, so see, Ashley, what do you think of this case?
So a 26-year-old female, first metatarsal pain after motor vehicle accident 2 months ago, rule out tibial sesamoid fracture. Here we can see some proximal retraction of that sesamoid and a lot of edema in the region of the sesamoid to phalangeal ligaments. So this is I think this is definitely a plantar plate injury. There also might be some edema of the flexor hallucis tendons / muscles. You can see increased edema along the plantar plate and this sesamoid to interphalangeal ligament there on the medial aspect.
Yeah, so here it's very nice. You can see the tear of the sesamoid phalangeal ligament medially, and it's intact laterally. So that's kind of nice example of this. Here's the coronal images through it. Let's see this one we follow back here. Looks relatively normal at this level, but if we continue going through it here, we can see the changes here. And here we're very proximal. So if we go from distally here, it looks pretty good, and then we go more proximally, and then we're getting into the area of the tear, and then in the area of the edema within the medial sesamoid, and an abnormal signal intensity within the intersesamoidal ligament as well. So this is another example of turf toe with fracture and injury to the sesamoid phalangeal ligament. Here's just another example. We can see edema within the sesamoid bone. We can see there's some proximal retraction and angulation and a tear distally here of the sesamoidal phalangeal ligament or tendon. Here are the coronal images. We can see the abnormal signal intensity here within the medial sesamoid bone, and the fracture plane is nicely seen on the axial images. Okay, let's see. Jennifer, are you next?
Yes, I am.
Okay.
So here there is lateral subluxation of the sesamoids.
Yeah, so
It looks more chronic to me, but
right.
I'm not sure if they have any recent trauma.
So this is chronic, and chronic injuries to this area. Typically, we see that there's marked atrophy of the muscles. This is someone who's really not ambulating right now well, but this is really a chronic tear of the sesamoidal metacarpal ligament on the medial side, and then lateral subluxation on both of the sesamoid bones. Not
both,
common
both
finding in older
sesamoids.
people. John?
I was going to say both sesamoids are subluxed
Right.
and need to be put in place
Okay.
surgically.
Okay. Ashu.
Looking at this one sagittal image, it looks like there is quite a bit of edema. I don't know how old this patient is, but looks like there's quite a bit of edema of the lateral tibia. I don't know if this is just a poorly healed, or this is just Salter Harris 1. Okay.
This is Salter Harris 1. So it's a. Jennifer.
Okay, so here again we have a pediatric patient. The physes are open, and we have this oblique fracture extending through the lateral tibial metaphysis. I don't see any definite extension through the epiphysis, so this is probably a Salter Harris 2 fracture.
Good. Ashu.
Another adolescent patient, open physis. I can see that I don't really see much. It could be some irregularity of the distal tibia epiphysis there. I don't know if there's a lucency extending through.
There is.
Yeah, there is. And
Our arrow is.
yeah, the arrow helps. Yeah. So it looks like it's extending through inferiorly. I think this looks like a Salter Harris 3.
Right.
It goes all the way through. So it actually Salter Harris 4. It goes superiorly as well. Okay.
Yeah, I think it's clipping a little bit of a metaphysis there as well. So I agree. And then if we look back here, there's your posterior malleolus. So this would be a Salter Harris 4, which we can see from the lateral projection. And then there's a lot of displacement here as well.
And these have to be reduced and fixed.
Yeah.
Not an easy process.
Yeah, so it's a comminuted Salter Harris 4. Okay, Jennifer?
Okay, so I believe this is the second metatarsal head. We have a couple images of the foot. There's some edema in that second metatarsal head. I'm not sure if this is like, is it Freiberg's infraction?
Yeah, which we can see here. And
I don't see any. Oh, there might be some cortical step off dorsally.
yeah.
So this is probably a non-displaced fracture.
Yeah. And you can see the second metatarsal head is often where when you're in on your toes, where you get a lot of force there. And this is Freiberg's infraction. And in the literature, a lot of people call these avascular necrosis. Again, it's generally recognized now that these are traumatic injuries from repetitive trauma, typically seen in women who wear high heels.
Before MRI, John.
Yeah.
That's one of the oldest fracture names I can remember.
Yeah, Freiberg's infraction. Okay. Here's just another example where we can see this a different kind of edema distally here. Here we can see a little double line sign. So in this case, some people might want to call this a AVN. But again, this is an area where you have a lot of trauma, and this is really Freiberg's infraction, and these are due to repetitive trauma. Okay, Ashu.
Okay, 11-year-old male with left heel pad pain and right lateral pain. Is that the right side on the right?
I believe this is left and this is right.
Right. So the proximal aspect of the right fifth metatarsal. There may be a fracture there. I don't know if that's just an apophysis. And then for the left heel, I don't really, I don't, some irregularity. Yeah, there might be a, oh yeah, there is a irregularity of that calcaneus. There might be a calcaneal fracture.
Here's a CT scan. Here now is right's on your left and left's on your right. Here's that fifth metatarsal base. You can see that little fleck of there.
It looks pretty well corticated. It's hard to tell, but
There's a fracture there.
is that a fracture? Okay. Okay.
Here
For me, it's hard to. Okay. It's hard to tell. I guess it's just an apophysis.
Oh, well, that's right.
Just
The other side's more mature. Sorry about that.
so that's just apophysis.
the oblique orientation.
Yeah, and this is the typical oblique orientation of apophysis. Fractures, avulsion fractures, which occur in this plane. Apophyses occur longitudinally here. Okay.
There are three different variations. But you know how I feel about variations.
Okay, right. So you can get a thing called apophysitis, which is probably, again, traumatic related rather than inflammatory. Which will, if you allow it to heal, it will heal on its own. It's called Islin's disease. And you get a lot of tenderness at the metatarsal base with ecchymoses and edema. And this is, again, an area primarily of trauma. You can also get ossicles in this location, os versalianum, os perineum, which we've already talked about before. And here's what they can look like in that area. Okay, say Jennifer.
Okay, so we have a 53-year-old male with lateral pain after a twisting injury, and we can see there's an ossific fragment more proximally located than expected for an os peroneum, so I'd be concerned about an injury, ossific avulsion injury of the peroneus brevis tendon with retraction.
I don't really see much of a donor site there. Okay, here's the MR scan.
Okay, so
Let me go back here. So we're concerned right about in here then, right?
yes. So there is some edema there, and it looks like there is an ossific fragment that is edematous within the peroneus longus. I would want to evaluate the peroneus brevis tendon.
Okay.
Here we can see again that edematous ossific fragment in the peroneus brevis.
Wait, in the brevis?
No, this is in the peroneus longus.
This is the cuboid, so it's the one coming under the cuboid, which I think is in the longest.
Okay, so this is the longus.
Yeah, let's see here. Yeah, and this was a fracture of an os perineum in the peroneus longus tendon there. And if we go back, you can see a little bit of a fracture plane right there. So this, you can get a painful fractured os perineum. Okay. So now we get to the infamous base of the fifth metatarsal in this particular area. So we can see the peroneus tertius tendon comes down and attaches here to the metaphysis. The peroneus brevis tendon comes down and attaches to the end. We got the cuboid there, and this is called the tuberosity. There's the base. Here's the peroneus brevis. I mean, this is the plantar fascia also attaches to this area as well. And so there are kind of three areas at the base of the fifth metatarsal. There's the shaft itself, then there's an area in between here around the neck, and then the tuberosity over here. which can be fractured. So fractures in this location are generally avulsion fractures from the peroneus brevis tendon. Fractures in the neck here are a problem, which we'll talk about in a minute, and then you can have more distal shaft fractures. So there are different classifications. In this case, type 1 would be an avulsion injury of the tip. A type 2 would be really kind of at the base here, which is also called a Jones fractures. And then a type 3 would be a fracture involving more the proximal diaphysis of the fifth. And of these, the Jones fracture is the one that's the most difficult to heal, has the biggest problems. So these are the different ones, typically called avulsion fractures, Jones fractures, and stress fractures. And the differentiation.
John, there's also fracture that goes into the joint.
Okay.
And that's another one. And there's a controversy whether you operate on them or not. The last one I treated was not that long ago, and she healed just fine. And that was some displacement of it, and I didn't recommend surgery. She did okay.
Good.
Some people recommend surgery for that one, but I didn't think that was a good idea.
Okay. And then there are other classification systems as well.
That one is close to the diaphysis. That's the one that's that 50% of the time will not heal, even if you immobilize it. That one winds up with surgery, which then will heal the fracture.
Yeah.
But the little chip fractures that you get avulsion of the brevis, that we leave alone, that usually doesn't cause problem.
Great, good. Yeah, so here are just one surgical indications if it's comminuted or displaced, if it involves more of 30% of the articular surface that John was talking about, or if it goes on to delayed union, then it's indication for surgery. And here we can see an avulsion fracture here of the proximal tuberosity. And let's see, we'll just go in here. And here's typical locations of a Jones fracture here with incomplete healing in this particular case. Okay. And here we can see more of a complications where you have a complication of a previous Jones fracture here and then an avulsion injury of the tip as well here.
And that we leave alone, but this one right here that you have, this needs surgical intervention unless the patient refuses. I've had that happen to me, and I put the patient in cast for 3 months. She didn't like it, but she healed.
Okay. And so
50% will heal, 50% won't. But if they don't heal, you operate on them, and then they will heal pretty much 100% of the time.
And this is a little bit distal for the typical Jones fracture, but again, it's in an area of high risk.
No, I don't think so, John. I think that's a Jones fracture, don't you?
Yeah, as I said, it's kind of in the distal aspect where you could call it Jones fracture, right?
Yeah, it's right at the junction of metaphysis and then diaphysis.
Right. And
these are the misery fractures. A lot of folks, especially specializing in feet, they'll operate on these. Yeah. There's a special screw that you put in there, and you put it in blind with X-ray control,
okay,
or fluoroscopy, and it kind of as you put it in, it tightens the fracture more and more as you screw the device in.
Yeah.
Kind of an interesting device somebody invented. I can't think of the name. And I'm supposed to leave it in permanently.
Okay, good. Okay. All right, let's see. Jennifer, what do you think of this one?
Okay, so this is a 49-year-old male with chronic lateral pain after trauma. It looks like there's a chronic appearing fracture of the fifth metatarsal base. There is some cortication and
Yeah, this is really the proximal diaphysis, I think.
okay. I think this is like a chronic non-union or malunion type of fracture. There's a lot of fibrous scar tissue, but there isn't any osseous bridging.
Yeah, so this is a non-union in this location. I think most people call this a non-union Jones fracture, uh, uh, even though it's really kind of into the metaphysis. But then these are really high-risk lesions in this location.
There are fractures that are sclerotic. I sure like to see an X-ray on this, but sclerotic and others are loss of bone. And the ones with loss of bone, you have to put grafts in.
Okay.
The sclerotic bones do okay. It just remove some of the sclerosis and put a compression device in.
Why don't we stop here and we'll pick up tomorrow, okay?
Have a good night, everybody.